Okay.
Bismillah ar-Rahman ar-Rahim. Hello, everyone. Welcome again to Ziada Academy. And we have today a very honorable guest. Is my dear friend and brother, Professor Shams Noman, Associate Professor of Ophthalmology and Head of Glaucoma Unit in the PSMMU University of Bangladesh. He has a very long experience, despite of his young age. As I mentioned before, a very talented surgeon in the field of the anterior segment, especially the complicated cases or the complex cases of glaucoma and cataract, doing the phaco technique and the manual small incision cataract surgery technique together with the glaucoma surgeries, if needed for trabeculectomy and the other means, all how to treat and how to deal with the complicated cases of lens-related glaucoma. Thank you, Dr. Shams, for your kind acceptance of my invitation and giving us from your valuable time to share with us your great experience and expertise.
Thank you so much, my friend, my dearest friend. I'm really very much delighted to be here in your academic activities, and I've been following for the last 2 or 3 years. You are doing just great, and I'm also learning. The whole world is learning from you, and it is really very great opportunity to share our experiences through this common platform. And I'm really very much happy to being invited by you. It's my honor, and thank you so much. Thank you so much.
Thank you, my dear. Really, it's our honor to have a scientific and the most scientific and the most talented surgeon in your field. Thank you very much, because I'm following your work. I'm listening to your great presentation and learning a lot from your amazing videos. So it's our honor. So we are waiting today for your delicious videos.
Okay.
Yeah. Okay.
Thank you.
Share your screen. Yeah. Share your screen now, please. Yeah.
So is it shared?
Yes. The pics with trap BCL.
The slide is visible.
Yes, lens-induced glaucoma, ficolytic heart.
Lens-induced glaucoma. Yes. So actually, I want to share one of my video, and very simple, but I like to discuss on this. And
yeah, can you go to full screen? Pinch the full screen button.
Okay.
Yeah.
So this is my MSICS technique. It's a very liquid cataract. You know, the patient had a intraocular pressure of almost 40 millimeter of mercury. After giving admission, I reduced first the intraocular pressure and reduced the corneal edema, made it visible, and then I did the surgery in this method. It's a very simple one, but it is simple. We have to make it simple, because if it is a phacolytic glaucoma, in that case, patient has a severe pain, raised intraocular pressure, severe inflammation. Sometimes there is some pseudohypopyon in the anterior chamber, lens materials in the anterior chamber, corneal edema, and horrible pain. In that case, some surgeons in the different parts in our country, and also I saw some surgeons, they have a tendency to do the operation in that they just giving some mannitol injection and do the operation in the same sitting. But I differ with them, because it it is a very complicated one. We have to make it simple. And to make it simple, I used to give them admission in the hospital, and to make him or her comfort, I had to reduce the intraocular pressure first until otherwise contraindicated. I used to give them hyperosmotic agent. If patient is diabetic, I don't use oral glycerol. I used to prefer injection mannitol, 20%, 5 ml per kg body weight, stat. And then within this time, the cornea sometimes clear. Even I have to give Diamox. In such condition, I don't give topical anti-glaucoma medications because the penetration does not good, as the cornea is very much edematous, and sometimes they have some preservatives, rather make some irritations. To me, it is better to give the hyperosmotic agent and Diamox until otherwise contraindicated. And I used to give them steroid repeated. If patient is non-diabetic, even I give the systemic steroid. And if patient is fine, the pain become reduced in the next day. My preference to do a B scan if as patient after reduction of the pain, because sometimes it is very much helpful. You know, the mechanism of phacolysis is when the lens is hyper mature, the lens capsule become very much thin, anterior capsule and posterior capsule. So in that cases, the anterior capsule, the cortical materials become leaked through the semi-permeable anterior capsule, and also the posterior capsule sometimes leaky, and some cortical materials goes behind the even in the vitreous. I have a lot of experience. So in that case, sometimes it will make me clear that there is any opacity in the posterior lens. Even sometimes in the village, people, they don't know what is the condition, and they don't give us the history. Sometimes I saw after doing the B scan, I saw a lot of associated vitreous, condensation of the vitreous. The patient has history of trauma. That was a traumatic cataract, and now it's become the phacolytic. So in that case, we have to think that it might be associated with the subluxation. So B scan is my, I used to do the B scan. And it's my, I always try to make the cornea become clear, because I have told you that it's a complicated case. We can make it a simpler one by giving a conservative treatment.
Yes.
I have a lot of second thoughts, even to my seniors. They have a tendency to do it as early as possible, but I don't do hurry. So here I have written the reduction of intraocular pressure, the reduction of inflammation. In that cases, I have to do the careful CCC and also jonular care, because the capsule become leaky. There will be a tendency to Argentinian flag.
Yeah.
So sometimes very, very, very small capsular excision I have to do. Sometimes I can enlarge. Even sometimes if it is extended peripherally, I used to use the venous scissor to make it again a very good rhexis. But it is very much important to do the rhexis as much as possible, because as postoperative, we expect a postoperative inflammation in such case. So if it is not a very good rhexis, there might be a tendency of people capture intraocular lens. And in my experience, I did some phacolytic or phacomorphic glaucoma just after the day after the admission.
Yeah, okay.
In that cases, I saw the postoperative inflammation is very high.
Okay, but you can wait, provided that the intraocular pressure is lowered by the medical treatment, systemic and local, right?
So what is your experience actually? What is your
My experience with such cases, which is fecolytic or phecomorphic in such intumescent cataract, um, I used to start with the medical treatment with intravenous mannitol, and topical anti-glaucoma with a non-steroidal anti-inflammatory drugs, and close follow-up for of this patient for 2 or 3 days. If there is a good response to the medical treatment, I will go for the surgery. But in some cases, when I feel that they are with very long time standing, standing elevated intraocular pressure with a very low potential of vision, like poor light projection, I would be worried about this patient, and I will go for an urgent surgery after preparation of the patient with mannitol intraoperatively. Sorry, in hospital preoperatively. But if I know that this patient is with recent history, with a good potential for the vision, and also a compliant one, you have to check for the patient's mind, if can withstand, if can follow your instructions, or may go for another, or may ignore your instructions. So I have to be strict with such patient and take them to the OR after preparation immediately. But I agree with you. We have to prepare our patient properly before going to the surgery, because it is not life-threatening. Maybe vision-threatening, but if under control, I can wait.
Yes. Perfect. Excellent.
Thank you very much. But the problem here is the challenging points of the case. The very high back pressure, the liquid material around the nucleus, also the difficulty of rhexis. The rhexis is horrible. Yeah.
Yes.
Yeah, it's very difficult. On the other side, how to do all these steps in this very shallow anterior chamber, how to save the nucleus and how to save the endothelium at the same time. On my, I have shared on my YouTube channel a video titled "How to Do Safely a Case of phaco in Very Shallow Anterior Chamber," and I started my surgery with paraceplana vitrectomy, paraceplana anterior vitrectomy, to decrease the pressure and to push and to let the nucleus to go back, and it was very, very easier. But after doing very minimal anterior vitrectomy through the paraceplana port, it was good technique, and I have done it. So, but you did your case very, very nicely.
And in case of phecomorphic glaucoma, I want to share one of my experience. In the phecomorphic glaucoma, a very shallow anterior chamber. Usually, one of my patient, I gave admission to the patient. Patient has a severe painful eye with phecomorphic glaucoma, and very interesting. That was an intumescent, and also the nucleus is very much hard, and patient have a both component, cortical component and also nuclear component. So for the nuclear component, the volume is more, and also cortical component is the lysis and intumescence tendency. So it's a combined effect. The very shallow anterior chamber and severe pain with corneal edema. I did a conservative treatment and I did the surgery. Everything was fine, surgery was good, everything, but patient vision is not good. Patient has a only counting finger in the even after the 2 or 3 days after operation, and when everything is clear, I saw that there is a full cupping, complete stitching is full. So then I was thinking that in a very short attack, why this Kapdruk's issue is more? It's a shallow anterior chamber. Then I did a mistake actually. I did a mistake. I didn't see the other eye. Actually, I was in a hurry and I didn't see the other eye anterior chamber. Then the other anterior chamber is also shallow. And I did the gonioscopy. And there is a total closure of the angle in the surgical eye. In the other eye, grade 2 angle. So primary angle closure suspect. So that was the case of actually chronic angle closure glaucoma. And patient, and you know, in the chronic angle closure glaucoma, the intraocular pressure is raised, that there will be tendency to cataract. You know, the glaucoma patient develops cataract very early, and also after trabeculectomy, the cataract develop early. You know, both we have problem.
Yes.
And that was that was the case of combined mechanism glaucoma, chronic angle closure glaucoma, and also phacomorphic.
Yeah.
So always, and my residents actually worked out the patient, and he has been followed up the patient for the last 6 months, but I didn't see. He just discharged the patient. Okay, fine. The cataract is, even it is not mature, Actually, that was the case of combined mechanism glaucoma, and I saw the patient has a vision almost 636 previously, and intraocular pressure was not perfectly measured, or maybe 20, 25 sometimes. But actually, when patient has a 25 intraocular pressure and 636 lens, at that time, the combined surgery was needed. And if a patient was done combined surgery, the patient could be saved. Everything goes to Allah. So ultimately, I did the peripheral iridotomy in the other eye. So that was my experience. So always I used to tell my student, if it is a phacomorphic glaucoma, please see the other eye. If other eye is normal depth, okay, it is a phacomorphic glaucoma. If other eye is very much shallow, you have to think that it is a combined mechanism glaucoma. It is better to do the combined surgery.
Combined surgery and counseling your patient about the guarded prognosis. I have perfect. I have fallen in such a situation just one time, so I have learned it from this situation to counsel my patient. Really, this is a good note and good advice to examine the other eye, to check for the disc of the other eye to see, and the angle as well. Also, the proper counseling of the patient and going to be safe medico-legally by the VEP and the RG in such patient. It will give you an idea about the electrical activity of the optic nerve. So I'm telling the patient that we are going to decrease the tension to lower the pain. But about the vision, we will see together what will happen after surgery. I'm not sure about the results in such cases, but in other cases you will be more comfortable to do. You're right, my dear. So what else? You have a lot of nice cases. Please, if you have another one.
Yes, can I show you one? Just
you need to sleep. I know.
No problem. I want to show you.
You have to come, Dr. Shams, to me to visit my center here to do LASIK surgery for you. It's not. It is not good for the ophthalmologist to wear glasses.
Yes.
Okay.
Yes. Do you do the LASIK surgery?
Yeah.
I think
myself, or I'm doing for the others.
Yes, as very good cornea surgeon, and I know the Middle East is they are very much cosmetically active. The people are very cosmetically active, and also the people from your country, that they are very much cosmetically active, and a lot of people used to go to your center to do LASIK.
Yeah, a lot.
So yes. So I don't know whether.
Yeah, a lot, and I have in the center, in my small center, in my tiny center, I have the first device in Egypt, or to be honest, the first device in Cairo from CSO, which is MS39.
Oh, really?
Did you hear about it?
Yes.
Yeah, it's fantastic one, and very accurate the diagnostic tool for the cornea.
So you do all types of corneal keratoplasty.
Yeah,
Sometimes, but you know, do you know the Sangwan?
Excuse me?
From India? Sangwan from India?
Someone?
Sangwan from LB Prashad Eye Institute?
No, I know
Now he's
I know Rajesh Samar Basak.
Rajesh Sinha
Yeah,
from AIMS.
yeah. Rajesh from
Samar
AIMS.
Bashak from
Rajesh Sinha from AIMS. Okay, corneal surgeon.
AIMS, yes. And Namrata Sharma is also
Namrat
very
Sharma, absolutely, yeah. Definitely she is one of the strong women in ophthalmology.
yes. I really, I sometimes I become astonished to see her performance. I'm really very much.
Yeah.
Can I show you some of my very, I'll have to, if you, I want to share my experience on, some tube implant in such.
Yeah.
Is it visible? Slide is visible?
Not slide, not visible as a slide, but as a page.
Okay. Just wait.
Yes, now I can see the C with the guitar.
Yes.
Yeah, Ahmed Bal.
Actually, I just see. Actually, just see the Ahmed valve implantation in the childhood pseudophakic refractory glaucoma, a journey towards musical hopes.
Yeah. Okay.
Actually, that was the case of
Before going
traumatic.
before going, what did you mean with the musical hope?
I'm telling it a musical hope. Actually, you know.
You mean directing
the patient in the people from the mothers or parents of the congenital glaucoma patient or childhood glaucoma patient, they are so much frustrating. And if you will do the surgery perfectly in a perfect manner, they're really very much hopeful. I'm telling it.
You would change a lot. You would change your life completely.
Yes,
you mean that?
And also, like if I'm doing my works very perfectly, I'm doing my favorite works. Sometimes when we are very much excited doing this, sometimes we love to start some music, and the enjoyment is very much perfect if it is associated with music like that.
Yeah. Okay. Perfect. Nice. Yeah. Okay. Go ahead.
So patient has a trabeculectomy 2 times. So superiorly, 2 times trabeculectomy. Now I'm putting an Ahmed valve. This is called the priming to see the patency of the valve.
Yes.
almost the most important thing is to make a very good peritomy,
Yeah.
almost 8 millimeter. The anterior margin of the Ahmed bulb should be placed 8 millimeter from the cornea. So very
Yeah.
good exposure is important.
Yes.
Now I'm cutting the tube after fixation the tube.
Okay.
So this is the 23G cannula. I'm just introducing the tube
The tube, yeah.
in the anterior chamber. It must not be 2 millimeter. Now I'm fixing the tube. Can you hear the music?
Yeah, very, 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 very fancy.
I'm covering the tube with the tutoplast. It is not available in Bangladesh, but I have to collect for some few special cases.
Yes, this is
It's a tutoplast.
This is petroglyph from which material?
It is a pericardium. Pericardium.
Yeah.
So very good. I just love this. Very expensive, but it is not available in Bangladesh.
Yeah.
Just can you think that how much fix it? How much you can control this, and it is not hard. Like dry discolorate is very hard, and very much biologically perfect for the human. It is actually dried pericardium. This is the name is tutoplast.
Yeah. It's protective for the tube from the compressing fibrosis.
No, if the tube is exposed.
Yeah.
If tube is exposed, here you can see the tube in the anterior chamber.
Yeah.
Cornea is clear.
Yes.
So if it is if tube is not protected,
the conjunctiva may be eroded.
Yes, it eroded, and it become exposed. And the most important thing is the possibility of endophthalmitis is higher.
Yeah. Okay.
If tube is exposed, then the tube where the tube entry is also exposed. So the conjunctival organism and a lot of things goes and comes from this area. So it's very dangerous.
Okay, it's very nice. It's very nice case showing the valve implantation as in a very simple and nice presentation. But I know in the fact it's not with such a simplicity.
Yes. Sometimes it takes a lot of time.
Yeah.
Very good assistance is important. Because if the assistant is good, then the many complicated surgery become more easier.
Yeah.
Okay. I want to show you another case. This is it visible slide?
Yes.
This is another case of Burwell tube implantation in a refractory glaucoma.
Yeah.
You can see.
Yes.
It is a pseudophakic case. Patient was underwent surgery in a diabetic case, and also trabeculectomy failed. This is a Burwell implant. The difference between the Burwell and Ahmed valve implant, the Burwell should be placed underneath the muscle.
Yeah.
Between the superior rectus and also lateral rectus muscle.
Yes.
So I have placed it. This is the most challenging part. Now the fixing, same way.
Its placement, yes.
8 millimeter from the limbus. the residual part is almost same. The problem is it is very large, and you have to and 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 I want to show you one thing, because as it is an academic page, here you can see that I am just blocking the tube with a suture, just
Yeah.
very tight suture.
Yeah.
I will share you why I am doing this. Now I am placing the tutoplast here in the same
Yes.
manner. The residual part is almost same, patch
Yeah.
graft and everything is same. I used to use the 80 Vicryl for the conjunctiva because it is less irritating, and sometimes virgin silk I am using. So the almost the same method. I want to share one thing here. In the barbell implant, it is not a valve.
Yeah.
Are you here with me?
It's like a tube with two wings.
Yes, it's the open. There is no valve here. So
Yeah.
immediate postoperatively, there will be hypotony, severe hypotony.
Yeah.
If it is a severe hypotony, in that case, some choroidal detachment and some choroidals and vision reduction is very complications occur.
Yeah.
Directly, water comes out through this tube and goes to the subconjunctival space. So it is better to just tight with the Vicryl suture. It is better to just stop the flow by tightening the tube. And in the Barvelt and Adi implant, Adi is from India, Arvind. They have the modified Barvelt with low cost. It's called the Arvind Aqueous Device Implant, or Adi. So, but then what is the question? Patient have a 40 intraocular pressure. I have done Barvelt or Adi implant, and I don't let them to flow. So patient intraocular pressure is 40, and patient has an advanced glaucoma. If it is persist, then the residual damage can be occurred.
Yeah.
So my question, this is my suggestion, not to do Adi or Barvelt implant in case of very advanced glaucoma. Complicated glaucoma, but cubic tissue, if it is 0.95, it is better not to do, because I just put a very tight suture and to prevent hypertony. But the Vicryl suture will be absorbed within 1 month, maybe, or then it will be open gradually.
Yes.
But within this time, the residual damage can occur. So it is better to do the Adi or Barvelt implant in a neovascular glaucoma where the intraocular pressure is around 30, and it can be controlled with medication, and the cupping tissue is 0.7, so it will not be within full cupping within 1 month, like that. So in that case, we can implant Adi or Barvelt. But if it is an advanced glaucoma, it is better to implant the Amit. You got it?
Yeah. Very, very simply explained. Thank you very much. I'm not glaucoma surgeon, but and I don't like the glaucoma, complicated glaucoma surgery like valves. But really, you have shown them very lovely. Thank you. Thank you so much for your great experience and the guiding expertise. Thank you, Dr. Shams,
Thank you
so much. Really, your residents and your fellows are lucky to be with you, because I know that you are a very helpful teacher. Thank you very much. And I know that this is your time is too late, and I don't want to bother you more, so I will let you to sleep now. but I will take a promise to make another meeting in the coming weekend with
Yes.
another nice presentations from your knowledge and expertise.
Okay.
Okay.
Thank you.
Thank you
Thank
very
you.
much. Thank you very much, and have a good night.
Have a good night. Thank you so much. Thank you.
Bye bye.
Enjoy with your family.
Thank you very much. Bye
Thank
bye.
you. Assalamu alaikum.
عليكم السلام ورحمة الله وبركاته.